good morning, good afternoon, good evening, if you're in that part of the world. Welcome to this second webinar in the webinar series of Advancing Sleep Diagnostics through Home Sleep Testing. Today's topic is about artificial intelligence in sleep medicine, and we will be asking questions about if it's an industry trend or a mainstay, and what artificial intelligence actually is in sleep. How can we make good use of this technology in sleep medicine? What should we evade when we are talking about AI? What are the common pitfalls in using AI in sleep medicine, and specifically in sleep diagnostics, of course. My name is Snorri Helgason. I will be your host today, but with me today is my dear friend, Dr. Jon Skirnir Agustsson, Director of Analysis, Data and Research at Nox Research here at Nox Medical. I'm not going to keep this longer. I'm just going to hand the virtual microphone over to Jon. Jon, welcome.
Thanks, Snorri, and thank you all for coming. I'm very excited to see so many of you with us today. So I want to tell you a little bit about AI in sleep medicine, so what we're doing here at Nox Medical, and maybe a little bit about our philosophy of how we approach AI in sleep medicine. I think there's a lot of things that we can achieve by applying AI and machine learning to sleep medicine and sleep diagnostics, particularly with regards to efficiency, with regards to repeatability. So if you show the same sleep study to the same AI algorithm, you always get the same result. And hopefully we can also use AI and machine learning to derive new information from the data we record in a sleep study, and using simpler sleep studies or using more information from the sleep studies to ultimately provide better care to the patients. And I think this is the underlying goal that we all share. We at my team, we like to talk about AI boosted humans. And I think this is really where AI can shine in sleep diagnostics, not as replacing humans, but really allowing humans to do better work, servicing more patients or servicing their patients in a better way. And let's just start by really going into the basics. You know, what are we meaning when we talk about machine learning and artificial intelligence or AI? Typically, we use these words interchangeably, but what we're talking about in comparison to conventional programming is that in conventional programming, you typically have a software engineer and he writes a program, and the program is just a set of rules. And then you can apply these rules to data to generate answers. But when we are using machine learning and AI and all these things, then typically the rules are so vague or complicated that it's not practical to write a program to capture the rules. But what we do instead is that we collect large amounts of labeled data, so manually scored sleep studies, for example, and we present this data and the scoring results to algorithms which are called artificial neural networks or deep learning or something like this. And when we present these data and the answers to these algorithms, the algorithms can adopt themselves and adjust a little bit so they can infer some kind of rules from the data and the answers. And the output of this, and this is what we call the training or supervised learning, is a set of rules. And then we use this in our software and we can present new data to these rules to generate new answers. And so this is what the users are doing when they're using the software. They're collecting sleep data, sleep studies, and they use the AI or machine learning models on this to, for example, score sleep stages. And I just wanted to show you an example, you know, what we're thinking about when we say that the rules can be very hard to define. And if you think about just very simple example, you know, what is a chihuahua and what is a muffin? And I think when you just look at a glance, you might even make some mistakes looking at this picture. But if you had a friend who lives on a different planet and he has never seen a chihuahua and he has never had a muffin, how would you write on a letter, you know, a muffin is something which is this and this and this, or a chihuahua is like this? Probably what you would do is that you would just collect a lot of pictures like this and write on the back of them, muffin, chihuahua, and you would hope that your friend would learn to recognize muffins and chihuahuas in future pictures. And this is essentially what we're doing in AI and machine learning, is that we just have the data, like these pictures, with an answer written on the back, and then we just give it to an algorithm, not an alien friend, and we just hope that they learn the rules that kind of capture what we are trying to show them. In sleep, we have, of course, the ASM manual for the scoring of sleep and associated events, which tells us all the rules, tells us all the data we have to use, and how we use the data. But I think anyone who scores sleep studies knows that it's not enough just to read the manual and then you can start scoring sleep studies. You need a lot of training first. And this is also the reason why we cannot just sit down with our software engineers and write the ASM manual rules into our programs, because there's a lot of interpretation that has to take place so that you can score sleep studies accurately. And this is what we're doing. And for example, when you're scoring sleep stages using our machine learning models, it's very hard to write in a program, you know, what is a sleep spindle or what is a K complex, but these are things that you have to look for to score sleep stages. But what is much easier to do is just to have manually scored sleep studies and present the EEG data and the scored epochs and just let the neural network learn, you know, how do the different sleep stages look like. So you just have to show them a lot of examples. And this is what we do. And we use an algorithm which is called convolutional neural networks, or it's often referred to as deep learning. And this is where we feed the recorded EEG signals directly into the artificial neural network. And the artificial neural network is just a big collection. It's much bigger than what you see in the picture, of very simple operations where the output from one operation is fed into a layer, we call them layers, into each node in the next layer. And then this model learns to predict the output, which is wake REM or non-REM 1, 2, and 3, from the sleep data that we present to it. And there is also one very nice trick that we use, and it's used, for example, in language processing, where the context matters. Is that these small circular arrows that are pointing on one of the last layers there, this means that actually the model can use information from the past and even from the future to predict the sleep stage of the present epoch. And this is, of course, something which is written in the ASM manual, that, for example, when you're scoring REM sleep, you should find, you know, when the REM sleep is, and then you go back in time to see where it started. And we try to capture this information into our neural networks. And once you have a trained neural network, of course, the question is, you know, how do you know that it's actually doing anything good, or it's doing something useful, or how do you measure performance? And I have to say, the ASM has also done a very nice job there, is that they have this paper comparing how individual human experts agree on sleep stage scoring. So the ASM has already given us the answers to the question, how do you measure performance and what kind of performance should you expect? And so we see these two tables, and they are called confusion matrices, not because they're confusing, but this is just what they're called. But the top table is comparing how majority scorers compare to individual scorers. And we see that on average, individuals, they agree well with the majority. And we also see what kind of mistakes people usually make. For example, if the majority is scoring an epoch as N3, which is the bottom right corner there, the most common mistake is that humans might score it as N2. And in the lower table, we're actually comparing how our machine learning algorithm fares against manual scoring of PSD studies. And we see that the performance is similar to what you would expect looking at the human data, maybe except for sleep stage N1, which is a little bit difficult. But what I think is more important is that we see that the kinds of mistakes that the algorithm makes is similar to the kinds of mistakes that humans make. So for example, if you look at the N3 epoch there in the bottom right corner, and we see that the most common mistake is to score something which is manually scored as N3, but the algorithm might score it as N2. And I think this is important to understand not only how the algorithm performs well, but also what kind of mistakes it can make, because it helps us to build confidence in that it's kind of capturing the same rules and the same essence as the humans from the data. once we had built up a lot of confidence in using AI and machine learning to classify sleep from EEG data, which is a well-known topic. We know how to measure success. We know what signals to use and all these things. We started thinking, can we get more information from a simpler sleep study, like a type 3 sleep study, where you only measure breathing and SpO2. And we developed this algorithm, which is called the Nox body sleep, where we're using activity from the device and the breathing signals from the RIP bands, so the white bands around the chest and the abdomen. And what we're trying to capture is that we know that in the physiology, there's a difference between non-REM sleep and REM sleep, and between sleep and wake. We're not trying to go any finer than this. We're not trying to go for non-REM 1, 2, and 3. We just say non-REM, REM, or wake. And what we're trying to capture is that, for example, during REM sleep, we see here in this picture, in the first 5 epochs, we have non-REM sleep, very stable breathing. And then during the REM sleep, breathing becomes very unstable. And of course, breathing is not always stable in non-REM sleep. You might have sleep apnea or hypopnea or snoring or something like this. So there are, of course, variations, but there are maybe different kinds of variations than what you would see in REM sleep. For example, in REM sleep, you might have the thorax contributing less to breathing, respiratory rate might be changing. And these are also different than what you would expect to see from wake people. And I think people who are very used to scoring sleep studies, they already have built some kind of an intuition for this, that yes, there is some information in the breathing signals about non-REM, REM, and wake, and maybe they even pull out some more information. So we're trying to capture this, and so it's something that is built on physiology, and we expect to find it in the signals, and then we develop the algorithms to try to capture this information. And here's just an example of an hypnogram. So on top, you see the sleep staging from a manually scored PhD sleep study. And below is the prediction or the estimation of the body sleep algorithm. And we see that the wake periods, they line up pretty nicely. The REM periods, which are the red one, line up pretty nicely. And then we just have non-REM, which is green for the Nox body sleep, lines up pretty nicely with the non-REM 1, 2, and 3 from the PhD scoring. But there's one maybe fundamental difference between the Nox body sleep and manual scoring of EEG data. And the fundamental difference is that if you don't know if you trust the model, you can always look at the EEG data and verify if the scoring is correct in a PhD study, whereas we don't have any established rules to score breathing data. And I think this is something which we are very, very cognizant about, and we want to somehow help the users to build confidence in our models and give them tools so they can maybe somehow look at the results and look at the data and come to their own conclusions. And there was a very nice result published by the group of Emmanuel Mignot when they were thinking about narcolepsy patients, and they do what they call the hypnodensity plot. And if you recall earlier when I showed the neural network, we had in the end the wake, REM, non-REM 1, 2, and 3. In these bubbles, we actually have, what is the likelihood, or what is the percent, or what is the likelihood of the model classifying a wake epoch as awake. And we can present this in this figure. So we see that in the yellow areas, which correspond to the wake periods, the model is saying, okay, maybe 90% of epochs I've seen like this, they were wake. And therefore we classify it as wake. And in the green areas, you see maybe like 100% of epochs I've seen like this, they were actually non-REM sleep. And that's why we say it's non-REM sleep. And then you see areas, for example, somewhere close to or like 1/3 of the picture, where there's like a red blob, but it's not scored as a REM period. And here the model is maybe thinking like, yes, I've seen epochs like this. They were scored as REM, but I'm not sure. So, and maybe this can help the user to identify areas where they should go and investigate and see if they trust the model outcome. So this is one part in our effort to kind of help people, to give them the tools to look a little bit deeper into the data. And when we're doing the development of these models, and for example, the body sleep in particular, what we start with is a collection of manually scored PhD studies. We take these studies, we have the 30-second epochs, and we pull out the actigraphy and the RIP data. And when you're developing these models, you take the sleep studies and you split them into 3 parts. So you take most of the sleep studies and put them in what you call the training set. Then you take a smaller portion and put it into what you call a validation set. And this is the data you used to develop the model and tune the parameters of the model. So you train a model on the training set and then you test it on the validation set and you see how it's going. And when you have a model, which you think is a highly performing model, then you have the 3rd data set, which you've never seen before. And you test if the model performance is still maintained on this hidden test set. And this is what we do for all of our machine learning models. And this is just what falls under good data science practices. But when we were doing something extraordinary, like the Nox body sleep, we thought we should take it 1 step further. We did all the training set, validation set, and hidden test set. But we said, let's see how it works in the real world. So we contacted a German professor, Christoph Schöbel in Essen in Germany. And we invited him to do a validation study using his own data. So it's from a sleep clinic where we didn't have data from before, scored by technicians we had never seen scoring from before. And maybe there's something in the population which is different to our training data. And this was published in this paper recently. So we did this real life validation using totally new data, like real world data. And we see, for example, the number of epochs scored as REM between body sleep and manual is very similar, also for the non-REM and wake. And we also see how high the correlation is between the AHI from the body sleep and PSD, total sleep time and sleep efficiency. And I think this is really an important question to answer is when you release these models into the real world, how will they fare in the real world? Because in the lab, you can always have a little bit overly positive results. Just in the end, I just want to talk about a project which is very dear to me because I think it's one of the most challenging AI machine learning projects we have taken on. And I think projects like these could also have the biggest impact on improving efficiency and improving consistency in the scoring of sleep studies. And this is arousal scoring. And we see here EET data, and towards the end, there's this red label, labeling a period where a human expert scored an arousal. And arousal is just a brief increase in the frequency of the EET data. And this is something which is very hard to learn by machine learning because arousals are relatively rare as compared to the rest of the EET data. Typically, they're not scored very accurately, and they can happen at any time. So there's a lot of things to consider there. And when we train our machine learning model and it scores an arousal, maybe like this blue box that we present, most of what the blue box is scoring is not labeled as an arousal by the human. So by default, you would have to tell the model, no, sorry, most of this is wrong, but there's a small part in the middle which is correct. So this is kind of the problem that we have to deal with the arousal scoring. And it took us a long time to make progress there. And in 2018, we made the breakthrough when the Physionet website hosted a competition, an international competition, where teams were scoring arousal from sleep data. And we had 2 interns with us at this time, and they participated in the competition and actually managed 2nd place against very fierce competition from big universities and even other companies who are in the sleep industry. So we were very proud of this, but this was 2 years ago. So since then, we've made a lot of progress on the arousal scoring, and hopefully we will release it as a medical product in the coming months. Just in the end, I just want to point to you guys, if you want to go a bit deeper, on this paper from the Journal of the American Medical Association, how to read articles that use machine learning. I think it's a great paper. It's written for people who are using machine learning models, so maybe physicians or technicians, and may not be experts in computer science or data science or anything like this. So with this, I just want to close. Thank you.
Thank you, Jon. Hopefully there's a comment in the chat. Someone has lost the sound. I hope we're not just talking to each other. But I'll assume that the sound is okay. I'm getting a nod from my technical team here. All right. But I wanted to start a poll while I ask you the first question. So I will be starting a poll for everyone to answer, and feel free to use the Q&A functionality here, and we will go through some of the questions here afterwards. So I'll launch the poll here now. So my first question to you, Jon, thank you for an excellent presentation, is actually, you touched a little bit upon this. You know, you talked about AI boosted humans in sleep. And one of the criticism that AI has got, you know, through whatever field of sleep, of medicine, is that AI can never see the full context, cannot see the whole patient, cannot see even the whole study, and make judgment upon that. How should we be addressing this one?
Yeah, I think it's a very important question. And so what I was presenting to you now were algorithms to score sleep stages, sleep states, and arousals. And these algorithms are only fed the physiological data that you record during a sleep study. So these algorithms, they don't know about the gender or age or anything else which might impact these people's sleep. So they have a kind of a tunnel vision. And I think this is definitely something which could impact the results, and something that humans could add a lot to the results of the algorithms. You can imagine just meeting a person, meeting a patient already gives you a lot of information about what you might expect from their sleep. And then you learn their history, maybe you have medical records, which are also adding very rich data, which kind of gives a much fuller picture. So, and that's why we talk about these AI boosted humans, is that these AI algorithms, they perform very well on most patients. And I think most patients are kind of normal, I mean, they're still patients, but they're kind of the normal patients. But then you have the patients which require more care, and maybe their sleep disorders present in a novel way or in a rare way. And I think what I would think with AI boosted humans is that you could maybe spend more time on these harder cases, and you could maybe have two people looking at the same sleep studies, and you can kind of give better service to this maybe a minority of the patients, but who require maybe a majority of the attention of the people.
Okay, thank you. I'm going to end the poll, and I'm just going straight into question number 4, because we got an excellent comment from one of the attendees here. Perhaps a better question for number 4 would have option 4 if respondents think their job will be affected by AI in sleep positively or negatively. Because yes, most of those that answered here, I mean the majority, 47%, said that their job will be affected by AI. And this is maybe something you would, you know, want to echo, Jon. I mean, this will have potential impact on the sleep medicine field as a total. And how do you respond to that?
Yeah, I think it's, of course, you know, I don't have a crystal ball, so I don't know. But the way I see it, and I think what we've seen when there have been like big steps in automation, is that repetitive, maybe kind of mundane work gets, maybe people will do less of this, and they will do more of a specialized work which requires, you know, more training or specialized skill, human to human interaction, for example. I think this is something that is going to be very hard to replace with machines. Mm-hmm. Even, you know, we have all this, you know, Zoom and everything now, but still just, you know, human presence. It's very hard to do that with a machine. And then also looking at the big picture and kind of seeing, you know, the holistic view of the patient. I think this is something which will also be very challenging to do with AI and machine learning in the near future.
Mm-hmm. And just to run through the other questions as well, almost 84% see a future in more automatic tasks in the sleep industry. But questions 1 and 2 are actually very interesting. Half of the people answering here to the question, are you currently using automatic analysis while scoring a sleep study, said no. And only half, or a little bit more than half, say they trust AI-powered sleep study to give an accurate diagnosis. So I guess you touched a little bit upon that in the confidence plot that you presented. do you feel like the industry should have done a better job in making this as an assisting tool? Why is people not trusting the automatic analysis? What is actually going on here? What's your take on that?
And I see also in one of the questions which is posted to us is that these neural networks, they are essentially black boxes. And so it's very hard to determine why is the neural network taking the decision that it's taking. And if you think about humans, we are also black boxes. I can come up with an idea and you cannot look at me and see why I made this idea. But what humans have, which neural networks don't have, is that if I make a decision, someone can ask me, Jon, why do you think it's like this? I think it's something different. And we can have the discussion. But with neural networks, you cannot ask the neural network, why did you say that this is REM and not something else? And this is, I think, why it's so important that we, as the developers of the tools, also think about ways that we can try to communicate to the user. Why is the algorithm coming up with the decision that it came up with? And I think this will actually help boost a lot of the confidence because, and we also humans, we have a very low tolerance for machines making mistakes. We have a lot of tolerance for humans making mistakes, but if a machine makes a mistake, then we have no tolerance for this. And I think that's also a very human thing, So it's machine is somehow, we don't have no empathy for machines, so it just makes us mistaken, and it's just a stupid computer. But again, we have to build this both with education, with outreach, but also give the users the tools to kind of ask the question: why did you make this decision and not that decision? And also maybe, and I think this is an active topic in AI research, is how do you feed back this information to the model? So the user says, no, I don't agree. And how do you feed back to the model? And so the model can actually learn and improve and do better for the user. But then again, with medical devices, we cannot adopt our models very quickly because we also have to have them registered with the authorities. So we cannot just release new models every day. But there's some mechanism that we need for feedback as well, and we need to take this into account.
Mm-hmm. Very good. We have a lot of questions, and just before I start answering, we start answering some of them. We definitely won't go through all of them because we don't actually have the time to do that. But we will try to answer them after the webinar as well in writing. And there's a question here about if we will share the poll results of the webinar. We can definitely do that. We will share the recording as well afterwards. I have a question here related actually to what we were discussing here. Let me see here if we can answer this question live here. There we go. Do you anticipate any shifts in the landscape of medical liability with a future increased reliance on machine learning models? Can you see the question here?
Yes, I saw this question and I really wanted to answer this one. And I have a very disappointing answer. I think it's, I don't have the answer. But we see this with self-driving cars, for example. We see self-driving cars and they have an accident and who is responsible. And there are a few things which I have to take into mind here. One thing that we as the developers of these tools, we have to be super transparent in, what are they intended to be used in? How do they perform within those boundaries that they're intended to be used in? And we have to be very clear that, we test them within some boundaries. Then the users also have to be a little bit responsible and not use them for outside the boundaries. You could think about something like sleep staging algorithm, which is developed for adults. Maybe it should not be used for children, for example, like something like this. So I think this is what we have to do, what the users also have to be doing. But then we also have maybe society has to learn how do we manage this. And then in the end, of course, there has to be some kind of laws put in place or regulations which kind of govern this, because I think at the moment it's a little bit undefined and maybe defined differently in different places for different scenarios. But I think this is one of the most important conversations that we have to have about AI in medicine in general. Mm-hmm. Is exactly who is liable, who's the how do you treat this and how do you go about it? And it's a team effort. It's, you know, it's the developers, it's the users, it's the society and the lawmakers.
Mm-hmm. Okay. Next question, is there a way that we can see arousals with non-EEG signal using AI? Think.
Yeah, it's a great question. I'm very optimistic that we can see something. There are things which are called autonomic arousals, maybe increased heart rate, pulse transit time decreasing, drop in the pulse wave amplitude, something like this. But they may not be like perfect predictors of cortical arousals. So there's some physiology there, and there might be a barrier to how much information we get from the surrogate physiological signals to the EEG physiological signals. For me, I would ask back, you know, as I'm an engineer, to the physicians out there, you know, does it matter the autonomic arousal versus the cortical arousal? You know, what is the implication of those two things? And that's also something which is not totally clear for me. But yeah, I think it's an interesting question, and I'm eager to find out, actually.
Yeah. Question. Then we have one here with, can you comment on the epoch by epoch comparison for the body sleep plus event location for the AHI? Can you take that?
Yeah, so the epoch by epoch comparison, I don't have it in my mind, and I didn't have it in the slide, so I would just refer to the paper. But we have a criteria. I don't want to say something which is wrong because I don't have it in my mind, but we have a performance criteria for this, which is a Cohen's kappa value, and I'm thinking it's like a Cohen's kappa of at least 0.6 for the 3 states, and we are performing above this. And now I would just have to refer to our manuals, because this is actually written in our manuals. What is the performance of the algorithm? And the other part was the AHI locations or something like this.
Yes.
But that's not impacted by the body sleep. So the body sleep is only looking at these sleep states, wake, non-REM, and REM.
Mm-hmm. Okay. I have a question here regarding, do you have thoughts on another outcome variable besides AHI in describing OSA?
Yes. And that's the short answer. I have many thoughts on this. And this is actually work that we're doing in collaboration with Scott Sands and Andrew Wellman in Harvard. We had a paper in the Journal of Sleep in September last year when we were presenting our endophenotyping implementation, which we collaborated with them on. So I would refer to this paper on that. But what we are thinking about, and those of you who know the work of Andrew Wellman and Scott Sands, is that they've been focusing for a long time on the endophenotypes, along with many other people, trying to determine, you know, what is causing sleep apnea in people. Is it loop gain or collapsibility or other traits? And we've implemented an algorithm to extract these traits from PhD sleep studies. It's not being used as a medical device yet. It hasn't been registered as such, but there are research trials and clinical trials which are using these metrics to predict the outcomes of patients who get different treatment than CPAP. So yes, but this is not related to our AI work per se.
Mm-hmm. Okay, maybe we'll take one more question. Do you want to pick one, Jon?
No, sorry, I've just been talking so much. I didn't read them so much.
But yeah, just to make sure that we will try to answer each and every.
There is one which I also I like because I see this sometimes, you know.
Only take the questions we like, just to make sure. Yeah.
For physicians in practice who have some experience with IT, but no data science or machine learning experience, like how do we learn more and how do we get involved? And I think this can also apply to other people. It's just people who are interested in AI and machine learning, maybe not experts in the field. How can they participate? And I have no affiliation, but I am a big fan of the Coursera courses, which are, there's a website called deeplearning.ai. And if you look for deep learning at Coursera, you see many great courses by them where they're teaching I mean, you can just sit down by your computer. If you know a little bit of programming, you can be training, very complicated neural networks in a matter of hours. There's one which I especially like, which is called AI in Medicine or something like this, which is a great course, and I really, really enjoy this. So I would say for anyone who wants to like put in a little bit of effort, these courses are totally worth it. You can take them. You don't even have to pay for them if you don't want to. So this is how you can get started. But if you're thinking like, how can you participate or how can you contribute? I think something that we can all do to contribute is to stay informed. For example, reading this paper in the Journal of the American Medical Association, and just be informed about, what is AI, what is machine learning, what is, realistic, and what is sci-fi. I think that's the most important thing we can all do. Then there are big data sets online which you can access with sleep data, where you can start building your own models. There are even on GitHub models which are pre-trained, and you can start playing with this. So I would look into the work of Emmanuel Mignot, Susan Redline, and more, who are making a lot of these tools available. So that's definitely a great place to start. And for industry, I think it's maybe, we have of course some limitations, but we're always happy to make connections with scientists and happy to collaborate with interesting and great people. And then of course with academic research, I think there are a lot of opportunities. What I find, because I manage this data science team, is that actually in our team, we are only one computer scientist, but we have physicists, we have engineers, we have psychologists and neuroscientists. So we have people who are coming with a very diverse background. And because the problem that we're solving is, it's multifaceted. It's not like a computer science project or like a bioengineering project. It really touches on many places. So I think there's room for everyone to participate and contribute to applying technology in medicine.
Okay, thank you. And with those words, I want to remind everyone that we're still recruiting for our Nox expert community. We will send you an information about that in the thank you post here. And along with the recording of the webinar itself and some of the the results from the poll, I would also like to point out that we have the third and last webinar on this in this series on advancing sleep diagnostics through home sleep testing, happening on the 21st of April, where we will discuss the top trends in sleep with Ingvar Hjálmarsson, the Nox Medical Chief Product Officer. He will provide some of his view and how Nox Medical views those trends and what we are actually doing about them. With those words, I'd like to thank everyone that participated here with your questions and with your engagement here. I really appreciated how many of you attended here. And if you have any questions, feel free to send us through info@noxmedical.com and just put in the subject line regarding the webinar. And also thank you, Dr. Jon Skirnir Agustsson, for joining me today. Hopefully I will see all of you in our next webinar. And until then, take care.
Thank you. Bye-bye.